A big welcome to this afternoon's Gastro Echo meeting, hosted by the Gastro Foundation in association with Project Echo at the University of New Mexico. And we're really excited about this afternoon because it's one of our patient blood management sessions, of course, a topic very close to our hearts. So just for those who may be here for the first time, this is a meeting held every Wednesday. The topics differ, of course, and just watch the emails coming around because many of the meetings will be primarily focused on gastroenterology and hepatology, but about once a month, we've got a patient blood management session included, like today. So if you have any questions in the course of this afternoon's meeting, please put it in the chat. That would be great. We like this to be interactive and really try and give some practical input to those attending. And then just to say, we had 84 registrations from 14 countries, including Angola, Cameroon, Kenya, the Maldives, that's where I want to go to, Mauritius, I want to go there again, Mozambique, Namibia, Nigeria, Sudan, Tanzania, the UK, Zimbabwe, Zambia, and South Africa, and many other nice places that I still want to go to. But great to have you all here. I believe we've got a strong contingent here from Kenya, about 20 people that will be joining us, hopefully, if all goes well, this afternoon. So without further ado, I'm going to introduce our speakers for this afternoon. And I'm very happy that two of my dear colleagues at Groote Schuur Hospital and University of Cape Town have agreed to speak this afternoon. And they are my co-conspirators, or some of my co-conspirators, in terms of getting patient blood management go off the ground in the Western Cape, and that is Dr. Christella, Alphonsus, and Dr. Matthew Gibbs. Now, the last thing we heard was that Dr. Gibbs was still busy with some quite serious surgery where there was a lot of blood loss. So we're going to have an interesting discussion this afternoon with very recent experience from his side about what one can do and should do in cases like that. But I'd like to hand over the microphone to Dr. Christella Alphonsus. She's a consultant anesthesiologist at the University of Cape Town and Groote Schuur Hospital, a wonderful person with a huge heart for people and a passion for patient blood management. And looking at what she has to present today, when we got together yesterday, I'm very excited. And Christella, it's great to have you here, and we look forward to your talk. You're welcome to share your screen, and over to you.
Thank you very much, Vernon. It's a great pleasure to join everybody and share my presentation. Okay, so I'm presenting, I'm doing a case presentation on perioperative patient blood management, and hopefully, will generate some interesting discussion. This is a sort of a hypothetical scenario designed to encourage discussion. So yeah, I hope people will understand and get into it. So our patient is a 32-year-old male. He's a known smoker and known patient who uses non-steroidal anti-inflammatory drugs for long-standing previous sports injury. He has a history of abdominal pain and melena stool and hematemesis of coffee ground vomitus, which when he presents to the gastroenterologist. An upper GI scope reveals gastritis and a posterior D1 duodenal ulcer classified as a Forest 3. At that stage, it was determined that immediate surgical intervention is not necessary. The patient was anemic, however, with an HB of 7.5 grams per deciliter. And I've put the MCV and MCH there, but obviously that doesn't necessarily always mean, indicate iron deficiency anemia. Sometimes your MCV, MCH can be normal, but here it is abnormal. And we've determined that this patient needs further anemia workup. So if you look at the screen to your right, this is from Andy Klein and Munting from 2019, where they've basically spoken or written of an algorithm for anemia. And they've basically said anemia in either males or females with an HB less than 13 should require further workup. With looking at serum ferritin, transferrin saturation, folate, vitamin B12, C-reactive protein, and creatinine. And for those patients whose ferritin is less than 30, they would be classified as iron deficiency anemia. And then you have those scenarios where you can have anemia with chronic inflammation and iron deficiency. Just particularly in those scenarios where anemia might be masked by chronic inflammation, a CHR, reticulocyte hemoglobin content of less than 28 is very useful, which would indicate the patient has iron deficiency. So the points to consider in terms of the anemia workup is to try and define what type of anemia the patient has. Next, the iron, basically the anemia workup shows the blood results with iron, ferritin, and transferrin sats quite low. A CRP, which is low normal, which means this is not chronic inflammation. Creatinine, which is normal, so there isn't a renal component to this. And a clotting profile that is also normal. So everything indicating towards iron deficiency anemia. If we look on the right-hand side, we see the 9-field matrix, which just shows that this is just the 9-field matrix of patient blood management, which looks at the first pillar, which is to optimize hemopoiesis, the second pillar to minimize blood loss and bleeding, and the third to harness and optimize tolerance. And you see that the first 3 pillars deal with the preoperative period. And essentially what is important here is that we note or we investigate the anemia, we optimize hemoglobin, and then we look at if the patient is on any medication, or if there's anything that would lead to an increase in intraoperative bleeding. And then further to that, we look at planning for surgery and anesthesia to minimize bleeding. The treatment for this patient, that was decided to go with IV intravenous iron and avoid oral iron due to the gastritis. The other treatment plan was smoking cessation, because obviously this is aggravating his symptoms, and to come up with an alternative analgesic plan for his chronic sports injury besides non-steroidal anti-inflammatories, and to also specifically in this patient to eradicate Helicobacter pylori. As I said before, the points to remember in the preoperative period is to optimize the hemoglobin. Here we've decided for IV iron, to look at strategies to minimize bleeding, and to plan surgery and anesthesia. However, the patient, even though they've been worked up for elective surgery, actually presented in an emergency situation with massive hematemesis with frank blood, and he was hemodynamically unstable. He had to be taken for emergency surgery. I'm told by the upper GI surgeons that they normally always do a scope on table before proceeding to laparotomy. And the scope, there was poor visibility on gastroscope, so they had to proceed to laparotomy. And the operation was a gastroduodenectomy to oversew the ulcer. And the frank bleeding actually came from the ulcer eroding into the gastroduodenal artery. So the surgery is quite difficult because it was a deep friable ulcer. There was ongoing bleeding with difficulty in getting surgical control. The immediate pre-op hemoglobin was 5 grams per deciliter. And here what we're looking at in the intra-op period is both the surgeons and the anaesthetists working in concert to achieve, first of all, surgical hemostasis, to provide some sort of blood conservation, and to follow a restrictive transfusion strategy. What we would do intraoperatively is, first of all, intravenous access is really important to have a large bore, fast flowing IV access to be able to give the patient blood and fluids to maintain their blood pressure and cardiac output. In this scenario, a cell saver was used to try and provide some sort of blood conservation. A massive transfusion protocol was activated. So our hospital doesn't have a massive blood transfusion protocol yet, but the plan is that the initial protocol would, 4 units of blood would be sent out of uncross-matched blood, and then another 6 units on request with other blood products. So in patients who you think or who will need more than 6 units of blood transfusion, you'd have to start thinking about platelets and fresh frozen plasma and cryoprecipitate and the components. And the other consideration is, because this is an otherwise fit person with no cardiac ischemia or other issues, that we could target a low hemoglobin trigger, a transfusion trigger for this patient. So I just wanted to quickly highlight the study from 2013, which was in the non-surgical patients, where they did follow a restrictive transfusion strategy for patients with massive upper GI bleeding. And what is notable is the graph below, where you can see the survival curves for those patients who were put in a restrictive transfusion strategy, and that the survival in the restrictive strategy was better. So as I mentioned, from the anesthetist side, intraoperative management of hemostasis, we need to think about giving the blood components, especially during massive transfusion. The other component is temperature management, to keep the patient warm, to facilitate coagulation. I also didn't mention here acid-base management and calcium as well. The other component, tranexamic acid, is a controversial issue. In most intraoperative scenarios where we are anticipating massive blood loss, like in cardiac surgery or neurosurgery, orthopedic surgery, there's good evidence and studies to say, you know, we should be giving tranexamic acid to reduce blood loss. But a recent study called Halt It, which was published in 2020, also in the non-surgical population, which looked at patients with massive upper GI bleeding, basically found that there was no benefit to giving tranexamic acid. It didn't change in terms of mortality, deaths due to bleeding, or all-cause mortality, and may have caused a doubling of venous thromboembolic events. Obviously, we can discuss this further. Some of the criticism of the study is just the timing of when the tranexamic acid was given, and also that they did change their primary outcome from all-cause mortality to death due to bleeding at 5 days, about halfway through the study. So there were some criticisms leveled at the study, but it is something that needs to be looked into. Point of care testing is important, especially to direct what or which blood components we're going to be giving this patient. You can see here this sort of teardrop graph from fibrinolysis and DIC from a bled out patient. In the post-op period, we need to continue resuscitation. It's really important because the immediate post-operative period is still considered a period of resuscitation and is critical. We need to monitor for bleeding, maintain normothermia, continue our hemodynamic monitoring, and continue looking at acid base and correcting acid base abnormalities and correcting hypocalcemia. We need to be cautious with anticoagulants in a patient that's bleeding and maybe have to delay post-operative Clexane until the patient is safely out of that window of bleeding. And then also ulcer prophylaxis specifically in this patient would be important. Following the immediate post-operative period, the other considerations are if this patient is still anemic and still has an HB less than 13, but is otherwise hemodynamically stable, to rather follow a restrictive transfusion strategy, and also to consider intravenous iron in these patients. However, the post-op period with, fluid shifts and edema, there's a lot going on during that stage physiologically for the patient. And so, yeah, we can discuss this further about the timing of treating post-operative anemia. So that's that from me. I think back to you, Vernon.
Thank you so much, Christella. That was great. I just want to welcome those who've joined us in the meantime, and encourage everyone, if you have questions or things that you want to mention, to put it into the chat box. We've got more than enough time to have a nice discussion about this. So I think I thought that was really great and a very, very nice overview. We don't have any comments in the chat box yet, so I think we can move straight on to Dr. Matt Gibbs and maybe leave some discussion time at the end for both of you. So next up is Dr. Matthew Gibbs. He's also a consultant hematologist in anesthesiology, the Department of Anesthesiology at the University of Cape Town, Groote Schuur. I see he is still in his favorite green suit. So Matt, and we hear you had an interesting day, behind the surgical table. So we look forward to hearing from you and your take on intraoperative patient blood management and how you applied that perhaps today. So thanks very much for being with us. It's really great to have you. We're welcome to share your screen.
We share the screen and we'll take it from there. Great. So you should be seeing my my slides here.
We're seeing the presenter view, Matt. I think if you probably want to show us the other screen or not. Yep, there we go. Yeah. Yes.
Okay. So the easiest thing to do is to actually just talk about my week, because to be honest, it's been fairly trying and testing. And I think it actually just demonstrates the role of the anesthesiologist in terms of my focus here of the intra and post-operative phase of patient blood management. Now, I came into patient blood management more from the side of preoperative anemia. I remember hearing a lecture from Andy Klein, who's well known to the PBM groups. He spoke in 2016 at the Anaesthetist Congress in Bloemfontein. I was blown away by the concepts of anemia, particularly functional iron deficiency, the role of hepcidin, and it's really sort of looking at ways of conserving blood. It's certainly become an interest. And in many ways, there's a lot of talk about preoperative anemia, and Christella was talking about that. I'm involved in the pre-assessment clinic here at Krugerski, and we see a lot of anemia. And as we know, in South Africa, in the surgical population, we see between 40 and 60% of patients with anemia, maybe high in some groups, particularly in orthopedics. And in the general population, particularly in obstetrics as well, we see a lot of patients with anemia, and I think iron deficiency is a large problem in sub-Saharan Africa. So sometimes we tend to focus our attention more on what can we do to get the hemoglobin up beforehand. But often in a resource-constrained setting, we have limited time to optimize or resources or identification. We have a patient who presents to us needing surgery today, and we need to start thinking about how can I conserve the patient's blood mass, and what is my role as an anesthetist in planning and controlling and acting as a point of contact for multiple disciplines. So we've mentioned the various, the ninefold matrix, the 3 pillars of patient blood management, is all well known to you. So my focus here is really looking at your second pillar, minimizing blood loss and bleeding, making use of any blood that is actually lost, and then harnessing and optimizing physiological reserve, delivery of oxygen, which is kind of the point of much of what we do. It's often the reason we want to deliver packed red blood cells, because whether evidence shows it or not, we want to improve the delivery of oxygen to tissues in our patients' bodies. And we believe that usually blood is a good way of doing that. So intraoperatively, there's obviously lots that we can talk about. Planning is probably one of the primary ways with which we can do so. The choice of anesthetic has a role to play as well, and we can have a chat about that. And the permissive hypertension is often a controversial topic, particularly in trauma settings. The use of cell salvage, which is something that I'll talk about quite a lot. Minimizing bleeding, and I will must emphasize the skills of the surgeon in this, cannot be overemphasized. Making sure the patient temperature is sometimes one of the most difficult things. In patients coming for scoliosis surgery, say a young adolescent with idiopathic scoliosis, often they are very exposed when they're on the table, and they may need 2 bear huggers, both underneath, forced air warmers underneath and on above. Otherwise, I've seen patients become profoundly hypothermic down to 34 degrees. And as we know, it affects hemostasis quite drastically. The use of anticoagulants is important. Depending, as Christella was saying, it can be controversial depending which speciality you're in, your concerns, but in many cases, we know that in cardiacs and orthopedics and obstetrics, that it is fundamental in controlling and minimizing blood loss. Point of care coagulation tests, I'm going to try and show you the benefits thereof. And then, as is mentioned, we want to look at the delivery of oxygen. And post-operatively, there's obviously, we need to focus on ongoing hemostasis, correcting any coagulopathy that has developed intraoperatively. And there's a large role to play for post-operative cell salvage. Then again, remember our patients that do bleed intraoperatively, they've lost a lot of blood, they've lost iron stores. So how are we going to actually improve the iron? That's going to be vitally important to the patient's recovery process and quality of recovery as they get through the initial post-operative phase. It may well that we can survive the first 3-4 days. And sometimes it may be difficult if we look at retrospective observational trials to show any mortality differences, but we do know that the quality of recovery will improve if patients' ferritin stores have been restored. So the whole point of what I'm trying to get to is that as an anaesthetist, we are a senior anaesthetist at the patient's bedside is a good role player in terms of going to the right people to try and optimize the patient's blood usage. And that means we've got a role to play with other surgical specialties, medical specialties, blood bank, nursing, and this is where I find it, anaesthetists become very passionate about patient blood management because we see the benefits, and what we really want is good outcomes for our patients. So let's start with just a very brief case. So this gentleman is not it was a bit of a borderline candidate for liver transplantation. He had some varices, decreased effort tolerance, long-term liver cirrhosis with repeated episodes of hepatic encephalopathy. He has lost weight, but he's still 123 kilograms. And he was listed for an emergency transplant 6 days prior to his receiving one. When it came to the transplant, we already knew that we were expecting some issues. He had an ejection fraction of 45%, which had subsequently improved. We knew that there were clotting issues with platelets and fibrinogen both being low, prolonged INR, and a baseline TEG already developed thromboelastograph showed prolonged R time and a decreased maximum amplitude. So right at the beginning of the procedure, we started with some blood products, pressurizing plasma, cryoprecipitate, and platelets. And as I expected during a liver transplant, there was significant bleeding. During the explant, we normally provide Tranexamic Acid, but we don't repeat it later on during the case. We maintain hemodynamics as best we can using noradrenaline principally. The use of a Low Cbpt technique, particularly liver surgery, is common practice, and the idea is to minimize any sort of back pressure on the liver and limit the amount of bleeding that occurs during liver resection. And in the same way, we do use that technique during liver transplantation. And I've mentioned the blood products that we used. In total, we managed to save 1.5 liters of blood for the patient and transfuse that back to the patient. He received no packed red blood cells whatsoever. The blood gas was almost normal throughout the entire procedure. It was a long procedure. It was 11 hours in theatre, and we elected to keep the patient intubated. But in principle, he actually would have been extubatable in some other centres, and he did extremely well. In transplant surgery, one of the hallmark features is to try and minimize allogeneic blood transfusions, and we were fortunate that we were able to avoid that. Now, in liver transplantation, this is not always possible. We did a case recently where we ended up using 4 liters of cell-saved blood but we also use 12 units of packed red cells and multiple other blood products in a patient who bled quite extensively. And so cell salvage is not always the perfect answer for everything. Its first recorded use was way back in 1880 by a gynecologist who used to take blood-soaked swabs and then squeeze them out and reinfuse to the patients. Unfortunately, it was associated with rather high mortality. But by 1931, people were getting quite used to the concept. And 1931, they started reinfusing hemothorax. We do a similar sort of thing already in South Africa using Sinapi drains, chest drains. And there is a port that you can literally plug once you've added a little bit of heparin, you can plug in your blood giving set into the port and reinfuse the patient's blood. The first cell salvage autotransfusion devices were developed in the 40s, with the first proper modern cell saver back in the 1970s. Our big issues are the phases, and the main phases are collection, your washing, and your reinfusion. We really want to use a dedicated double lumen suction device when we're collecting red blood cells from the operative field. One lumen actually suctions blood from the operative field, and then we have another catheter coming down that adds a certain amount of heparin-infused heparinized saline to the salvage blood to avoid clots forming within the suction bottle. This anticoagulated blood is then passed through a filter and then is collected in the reservoir, and they centrifuge the blood to achieve and wash off all the components of the blood. So we're just left with mostly packed red cells, which are suspended in normal saline, with a hematocrit of between 50 and 80%. The washing process removes almost all free hemoglobin, plasma, platelets, white blood cells, and heparin. So you should not have a heparinized patient at all. So this is just a schematic demonstrating this. Just use my laser pointer. So I think this is one of the advantages of this process, is that it tends to, if you can maintain one continuous circuit at all times, which makes it, in some circumstances, acceptable by Jehovah's Witnesses, depending on their beliefs and what they will accept. Large amounts of saline are used for washing, and once the centrifuge is finished, the remaining packed cells get put back into a bag, and then you can immediately transfuse back to the patient. There are, of course, potential risks, as with any medical procedure. The washing process and the suction process may result in hemolysis. Air embolus is always a possibility. Some non-hemolytic transfusion reactions, and of course, because you are suctioning up an open field, depending on what is happening within the abdomen, wherever you're working, there's a risk of contamination. But these risks have generally decreased with the various technical advances that have occurred, with adequate training and with increased experience with the process. In the Cleveland Clinic, a retrospective review of adverse events in using cell salvage showed that the risk of the incidence of adverse events was much lower in the autotransfusion cell salvage blood class versus your allogeneic products. Got a very high erythrocyte viability because there's no storage lesion that occurs in these patients. The blood is fresh, goes straight from the patient, gets washed and straight back. It's not stored, there's no additives, and anything that's added, like heparin, is washed off. Which means that, of course, the normal biconcave disc shape is maintained. So theoretically, you should have improved oxygen carrying capacity and tissue oxygen delivery. So that may be a benefit of a stored blood. In terms of where we actually use it, there's a lot of discussion. I would refer you to the South African Society of Anesthesiologists PVM guidelines, which were extensively revised last year with a large degree of help from Professor Lowe. in terms of when looking at all the literature, there seems to be a big push to using the cell salvage whenever you're considering that your blood loss is going to be more than 500 mils in high to medium risk surgery. It is still used in obstetric major hemorrhage. And in fact, it's common use in even elective cesarean sections, particularly in the first world setting. When you're worried about malignancy obstetric hemorrhage, there's a recommendation to use a leukocyte filter, and I'll show you that now. And of course, you can continue this way into the post-operative period. And there are plenty of use of the perioperative drains, using drains that's fresh blood coming from, say, a total knee replacement, and those can be reinfused into the patient. The Anesthetic Association of Great Britain and Ireland have also a number of indications for the use of cell salvage. And again, I'll mention patients that have objections to receiving allogeneic blood. They often will accept the use of cell salvage. In obstetrics, it's very important to recognize bleeding early, and you will see why I mention this now. Fibrinogen levels are very important in patients, in obstetric patients. We know that our fibrinogen levels do go up during pregnancy, expecting levels between 4 and 6 grams per liter rather than the classic 2 to 4. So as soon as your fibrinogen level drops to less than 2, it's almost 100% predictive of peripartum or postpartum hemorrhage and should be replaced. And cryoprecipitate, where should be the first port of call in this case. So there's a lot of concern about amniotic fluid embolism, but the washing mechanism certainly removes most of any sort of gunk that we're worried about. And then putting the patient's blood through a filter, a leukocyte depletion filter, completely reduces the contaminants quite dramatically. So you cannot find any squamous or very little squamous fetal cells or amniotic fluid derived tissue factor, which is probably one of the major mechanisms behind amniotic fluid embolism in patients. In fact, they don't find any differences compared to what you find in normal maternal venous blood. So using the right filter, particularly in patients who you're concerned about malignancy, has a similar sort of result. And in fact, it is used widely in patients with malignancy, for example, having esophagectomy, where there may be concerns about major blood loss. Again, as I mentioned, this review article from Gaucho and Wong in Anesthesia and Analgesia, again in the obstetric population, but this can be extrapolated to many other cases, it shows that how cell salvage blood is useful, has minimal adverse outcomes, and it has very little risk of bacterial contamination, which is always a concern. So we move on to my second case, and it's more to sort of illustrate how this all comes together. So this 32-year-old lady has come for a cesarean section. She's known to have a previous cesarean section without any complications, but she's now diagnosed with major placenta previa. She probably got an accreta. They're not entirely certain whether it has gone through the bladder wall or into, or is it just adhered to the bladder? But there's I've already seen the gynecologists involved and the obstetricians, and they were quite concerned. And we are really starting with a hemoglobin of 9.1. There was minimal time to preoperatively improve this patient's hemoglobin. So there's a lot of, what are our strategies here? I mean, do we need to delay for 5 days, 4 days? If she starts bleeding, what are we going to do then? Can we optimize this patient any further? And probably not. So intraoperatively, as we kind of predicted, we had massive hemorrhage, and estimated blood loss was at least in the range of more than 6 liters. We used 5-packed red blood cells, 3.5 liters of volulite or colloid, whatever you choose, and 1.5 liters of crystalloid. We ended up giving a total of 2,500 mils of cell-saved blood back to the patient. So I would strongly consider that we would end up using a far greater amount of packed red cells if we had not used cell salvage. It is rather efficient, where the leukocyte depletion filter did not slow the retransfusion process down very much. And then we used another technique which really aided in guiding us in our perioperative management of the patient. There was concern, of course. You remember that when we wash the blood, we remove all coagulation factors from the blood. So there's a concern we're going to develop a coagulopathy. So the TEG6 is a thromboelastogram. It is sort of the most up-to-date point-of-care viscoelastic testing that we have been able to obtain, which can be actually placed right next to the patient. And the advantage of it is that it allows us to get a basic TEG within 10 to 12 minutes. So this is an example of the rapid TEG. Within about 12 minutes, we're already able to get an R time, an estimation of the angle, and we can already see that our maximum amplitude is probably going to be decreased. So we've got three things. We're going to have a prolonged R time, suggesting that pressure-frozen plasma would be useful. The alpha angle is down, so cry would be a good idea. And to be honest, we were not surprised by that finding, and the maximum amplitude was decreased. And so we administered all three products. And in the immediate post-operative phase, we did a more formal TEG, which is down in our laboratory downstairs. And as you can see, the TEG is vastly improved with only was a slightly decreased maximum amplitude. Given the patient is not currently bleeding at the moment, there was no indication to give further blood products. And I think this is where the power of viscoelastic testing can be shown, is when you are applying it to the patient right in front of you, and you can tailor-make your approach for what blood products are necessary so that your overall blood product use is decreased. So the idea is that we, as much as there's many other things as I've mentioned, for example, like the use of regional anesthesia, which has been shown to decrease blood loss. And in fact, the use of spinal anesthesia has been used in patients with centroprevia before. But we play a role as a link between different practitioners in the patient blood management field. We see patients pre, intra, and post-operatively, and managing the hemodynamics is an intrinsic part of what we do. So if anyone wants to know what we actually do, it's something like this Venn diagram. This is one of my favorite Venn diagrams of all time, especially the sommelier part. But I do think a lot of our skills sets fit in with patient blood management. And yeah, if you've got any questions, I'm very happy to take them at this point. Thank you.
Thank you, Matthew. Matt, that's a great last slide and a wonderful talk. Really enjoyed that. So yeah, I think both between you and Christella, you've really covered quite a bit of the spectrum here. I've noticed that we've got a question in the chat by Wisdom Udombe. I'll come back to that in a moment. So I just want to start with one question about cell salvage first. Do you want to perhaps just share with our attendees what you would consider maybe absolute contraindications for cell salvage? When would you not use it?
So I think so. The main contraindications where you're concerned about major contamination that you're not going to be able to get rid of. So if you've got massive feculent contamination of, say, despite a trauma setting, a stab abdomen, and you've got feculent material filling the abdomen, or severe sepsis, if you've got quadrant contamination of pus, is a very thing be very unwise to use cell salvage in that circumstance. But anywhere you got ongoing bleeding that's sort of clean, we use it on a regular basis. For example, in scoliosis surgery, major orthopedic surgery, we've used it quite extensively with femur replacements for patients with sarcoma. But important, as I mentioned, you must use a leukocyte depleted filter in those cases.
That's great. And I think there's also, I believe, some products, if you've got certain products in your surgical field, that you don't want to get that back into the salvage. Hey.
Yeah. So if you're using if you're putting in hips and you're using implants, that cement that may be contaminated.
No, great. Thank you very much. So our question refers to the tranexamic acid, and maybe we can ask it to both of you. The question is, can we have a clear answer on the tranexamic acid issue and indication from the panelists? The HALT IT study, to those who read the Lancet article, there was half of the patients who had liver disease and suspected variceal bleeding, and these patients had a greater risk of death. They accounted for 3/4 of the deaths, and we cannot then say tranexamic acid is out completely, given that cirrhosis patients have a mixed fibrinolytic phenotype, but the other GIT bleeding causes to present, I guess, compared to the other GIT bleeding causes. Wisdom would like the presenters to comment. As I saw, the second speaker used tranexamic acid in their patients. Thank you for your comments, especially on GIT bleeding and tranexamic acid. So let's hear. I don't know who want to go first on that.
I can comment in terms of the use of the tranexamic acid in a liver transplant. Just remember that it's the initial phase only that we use the tranexamic acid, and then during the actual anhepatic and neohepatic phase, we prefer not to use it, especially because with the new liver, you get a procoagulant sort of phenotype developing, and you're concerned about developing clots, especially in your neohepatic artery and the portal vein, your venous connections. So it's only used in the specific period of the surgery.
Great, thanks, Matt. Christella, do you want to add anything to that?
I think just looking through the paper and looking at some of the comments made about the trial, you know, yeah, Matt and I use tranexamic acid extensively, you know, especially in our patients where we anticipate major bleeding. And I do a lot of cardiac anesthesia as well, and it's well documented to save blood in that scenario as well. So I was quite surprised by this trial, to be honest. One of the points that came up is the timing of the tranexamic acid. You know, as compared to like the CRASH trials, which were in trauma patients, where there's a sort of predicted point at which you know the patient is bleeding. Meanwhile, with upper GI bleeding, it sort of can be ongoing bleeding. And I think the mean time to randomization was about 22 hours in this halted trial. So there were comments about, you know, was it really effective at that stage, because there was a huge delay anyway in giving, or not delay, but there was a very long time period of bleeding before it was given. So, you know, it would be interesting to see going forward. I think there is another trial that's planned in sort of upper GI bleeding patients that's to come. But yeah, I'd like to hear, you know, the paper came out in 2020. So, and it's, by the way, this is non-surgical patients. So this is upper GI bleeding, but not patients who had surgery. So yeah, I'd like to hear what other people feel about it.
I think those are great insights, and I think it emphasizes some key points about tranexamic acid use. So I think the first thing about it, like Christella said, is the timing. You want to use it when you use it as close to the start of bleeding as possible. And with gastrointestinal bleeding, you obviously don't often know when it started. It could have started quite a while back. And I think the interesting thing also is that the previous systematic analyses of studies actually did show a mortality benefit compared with anti-ulcer drugs, but maybe not so much in terms of rebleeding and surgery or transfusion requirements. And that was interesting. And it was also one of the comments that was raised in a perspective paper in the Annals of Internal Medicine, where they talked about the HALT-IT trial, is that they were wondering about whether the improvements in supportive care did not allow us to see the benefits here. But there were some limitations. And one of the important limitations to this study was the fact that the inclusion criteria was not that well defined. They actually say it was quite poorly defined, specifically in terms of trying to categorize individuals' patients' risk for bleeding to death. And that can obviously make a huge impact on the final results. But the question remains, so what do you do? I mean, I'm sure that's what the people in the audience want to know. And I think the answer is very practical. If, with what we know at the moment, is we don't have strong evidence that it works as a routine. But if you've tried all the other measures and your patient keeps on bleeding, and this, what I'm quoting from this Annals of Internal Medicine paper as well, this perspective paper, and these people are from both from Boston, some solid people in the field. The suggestion, which I agree with, is then you give tranexamic acid. I mean, after all, you're trying to save this patient's life, but we cannot recommend routine use. And I think Wisdom made a very important point. Are we really able to, and it's one of the key things of research, can we generalize the findings to the typical acute upper GI bleed patients if 3/4 of the patients who died were actually liver cirrhosis patients? It's a difficult question and important question. There's a lot of other clotting problems as well. Matt, I see you've got a comment as well.
Yeah, I just, I think we need to be guided by evidence in lots of different fields. Tranexamic acid has a long history of very safe use in appropriate doses. We know it's beneficial in diverse groups, from neurosurgical craniosynostosis surgery to the big woman trial in obstetric hemorrhage, which potentially may save hundreds of lives across Africa. In patients dying from postpartum hemorrhage. So I think it just needs to be used in a logical, sensible manner, as you say. But I think let's see what further developments may occur in this field.
Great. I see Wisdom's response. Thank you very much. He agrees. Can we get the reference for the Annals of Internal Medicine paper? I'll quickly see if I can find it for you, and I'll put it in the chat box. In the meantime, Lee Ngugi asks, can you use cell salvage in pediatric surgery, neonates, etc., considering their reduced blood volume compared to adults? I'll open that question.
Yes, I'll take that question.
Okay, Matt, go for it.
So yes, in brief, yes, you can. You do get pediatric bowls that are specifically made for children. I don't know what the smallest bowl is. Unfortunately, I don't have my tame technician here Kirsty Skelding, to come and help me with an exact answer, the size of the bowls. But yeah, there are pediatric. The use is quite widespread, particularly in first world settings.
Excellent. Okay, let's see. We also had a question about how do we access the recorded online discussions. And I see Karen Fenton has answered there at the Gastro Foundation website under the G-ECHO tab. So you can all go there if you want to look at these again. Often there's so much information that one can't process everything in one sitting. So please go and have a look. There's a number of other interesting talks on gastroenterology, patient blood management as well. I have in the meantime found the citation on PubMed. There it is in the chat box, Horton and Feuerstein, I guess, if you want to have a look at that. That's an interesting perspective discussing the strengths and weaknesses of the halted trial. Lovely. I see it's 17:27, so I have to thank our speakers for being so brilliantly in their time management. That's really fantastic. The talks were very appropriate, and I think I personally have so much to learn about intraoperative and post-operative patient blood management. It's not my natural place where I spend my time, so thank you. I've learned a couple of things today from both of you. I want to, apart from Christella and Matt that I'm thanking here, I want to thank our ECHO University of New Mexico team, our ECHO India team that made this possible. I want to also encourage everyone to just fill in the feedback form in the chat. Please, we really want your feedback so that we can make this useful and meaningful to you and improve the session every time. We mentioned the recordings that are available on the website, and a special thank you to the Gastro Foundation, to Cheryl, to Karen Fenton, who's set this all up. And then next week is the gastro-echo endoscopy session with colonoscopy as a topic. So hopefully many of you will be able to attend that as well. And I can see here that there's a couple of people in the chat box that are thanking our speakers for their excellent presentations, and I can just very much agree with that. So with that, thank you very much. I forgot to thank Chris Cassianides, the person sitting quietly there on his couch, who's doing a huge amount of work around Africa and now the world. I don't know, he's recently also become part of a WHO strategic committee to work on patient blood management, and it's very exciting for me to work with him on so many PBM ventures. And maybe I may use this opportunity, if you don't mind, Chris, to just let everyone know that there's going to be a patient blood management conference in Cape Town in June that will be done as a combination in-person and virtual meeting. So please, if everybody, if your interest has been piqued, that may be an opportunity to learn a lot more about a lot of other aspects of PBM. With that, have a lovely evening, and goodbye, everybody.
Thank you, everybody.
Thank you.